So we are now back to part 3, reformat. To remind you of where we are in the lecture, we've talked about review, we've talked about reducing your dose. So now we're at the point where you've obtained your CT scan and you're going to use software technology to make it look even better. So you've already done the part of lowering the dose. Now it's time to make those pictures look as good as possible. So there's a few reconstruction algorithms out there. The oldest and simplest is so-called filtered back projection, FBP. The second, more recent and fancier, is statistical iterative reconstruction. It's going to give you better pictures, requires fancier software. And the most recent out there is something called model-based iterative reconstruction. This one, the latest and greatest, allows you to reduce the noise a lot, allowing a dose reduction of 52, in some reported cases, 99%. Well, how is that possible? It's almost like no dose. Well, what that means is the radiologist chose to have a very low dose study and then used model-based iterative reconstruction to make those pictures look prettier. So let's think about that in another way. You've got your CT data, you put it into the computer. The older technology, filtered back projection, gives you a head CT, which I've altered here for the sake of teaching, but you can see that it looks grainy. Not so great. Well, statistical iterative reconstruction takes the information and, as the name implies, iteratively looks back at the original data set and generates an image that looks better, that is closer to the truth. It takes more time, it's mathematically more complex. Model-based iterative reconstruction is a big black box. It's proprietary information. It's akin to and includes statistical iterative reconstruction in addition to other predictive models about what it expects the anatomy to look like. Now this takes, even on the latest computers, about an hour. It's not really going to be applicable to the ED setting, but for outpatients, this might be an excellent solution. And it has the highest quality study that will most mimic the truth and have the least amount of noise. That basically, as you advance to the more fancy iterative reconstructions, you get better acquisition of real information, excluding the noise. There are different names for each of these different reconstruction methods depending on what vendor you're talking about, but they do exist for multiple vendors. Now, let's see some sample. This is just a phantom and filtered back projection. It just looks like noise. It looks like nothing. If I asked you to find the abnormality, you'd say, I don't know. I see a lot of black and white dots. I don't really know what I would choose. It all looks the same because the noise and the finding are all blurred together. But model-based iterative reconstruction, that same set of information, like you can see something that is different from the rest. It stands out. Now looking back, you can sort of hallucinate where that was on the filtered back projection, but it's a lot easier to pull out the real information and exclude the noise when using the reconstruction method. So here's an actual patient example. We have a CT scan, we see some bones and we see some organs. It's not a very good looking study. I don't really know what we're looking for here, but model-based iterative reconstruction, everything is smoothed out, the graininess has gone away, and there's something now that finally stands out. There's a stone, a distal ureter stone causing obstruction that was really hard to see before, but now we can see it from the same set of data, meaning someone had to choose to make a low-dose CT scan, and it looks scary and ugly on the FBP, but you wait, you give it an hour, and now you have useful information. So it took some patience to get this. In terms of noise versus dose, the more dose you have, the less noise you have, and that will apply to all the reconstruction methods. The hotter the scan, the prettier the pictures. Now, you can see that depending on your reconstruction method, you still have that same phenomenon. Higher dose, prettier pictures. But notice, at the low doses, there's a huge difference in noise. If you have high dose, that difference is not as great because all of those lines converge as you go out on the graph. Meaning, at high doses, you're not going to be able to tell the difference between these reconstruction methods. That these fancier reconstruction methods really earn their keep when you've lowered the dose, but you had to make that choice. So what about making some comparisons between the two most fancy reconstruction methods, SIR and MBIR? So let's look at regular doses. This is a blown up section of lung. And I can't really tell the difference between these two. We've applied model-based iterative reconstruction, and the image on the left looks the same as the image on the right, because when you have a higher dose or even regular dose, you can't tell the difference between these. But what if we go to an ultra-low dose? So we showed 1 millisievert. What about 0.08 millisieverts? This is, less than a tenth of the dose. Now the image on the left, using just the statistical iterative reconstruction, looks pretty grainy. It looks like, some bad photo of the moon, but now you've smoothed it over and you can actually make out individual vessels from this blown up segment of lung. That now finally at the ultra low dose, the model-based iterative reconstruction has really earned its keep and proven its worth. So much better. Here is ultra low dose. This is that grainy image that you saw before, and now you can see where I was taking it from, that segment of lung there. And you can see that this image is pretty grainy, and you would feel worried that you'd be missing stuff looking at an image this grainy. But you apply model-based, and now it looks smoother. It's not perfect. It's not as good as the higher or regular dose study, but it's pretty good, and probably good enough for a lot of indications. This is much better, and again, we've achieved much better at a low dose using this fancy reconstruction method. So this is one thing we do at UCSF is we offer an ultra low dose chest CT. We use it for pectus excavatum, we use it for airway foreign body, we use it for cystic fibrosis, we'll use it for patients who have high cancer predisposition like Lee-Fraumeni syndrome. And you can see these are chest x-ray doses, but a CT at said doses that looks pretty good and pretty amazing 3D reformats from such a low dose. And again, this is a DLP of 6. We were talking earlier about abdomen pelvis targets of 200 and 500. So we are at the bottom of the barrel in terms of the dose that we're achieving, 0.08 millisieverts. Put into context, a chest x-ray is 0.02 millisieverts for a frontal, a 0.06 millisieverts for a lateral. Together, a frontal and a lateral chest x-ray is 0.08 millisieverts. So this is really CT at chest x-ray doses, which is pretty amazing. But you only get away with it because A, you've got lungs, which are a natural negative contrast in the body, and B, you've used this reconstruction to salvage the image information. Now this kind of brings us back to my take-home message. This was an image that I showed earlier. This is the same patient, had 2 different CTs at 2 different dates. On the left, DLP of 40, that's really low. For an abdomen and pelvis, that's really low. And then DLP of 80, which is more reasonable. And you can see it looks like diffuse liver disease on the left, and you can see it looks like a totally normal liver on the right. And I was personally fooled by this case. I wasn't sure, but I thought maybe it was real. And this was letting me know that in our group, we had pushed our doses too low, and we needed to dial it back up a bit because we were starting to allow too much noise that was compromising diagnostic quality. But that told me that I had pushed the threshold as far as it could go. And the notion of ALARA, as low as reasonably achievable, is exactly this, that get it as low as you can because we don't know these risks and what they'll be. Let's assume worst case scenario, linear no threshold. We want to lower those doses, but not at the expense of image quality. We still need to use these studies to gather information. So again, you get it as low as you can and then no further. So just to remind you, numbers that I think are useful to keep in the back of your head when you're looking at your report, and this only applies to abdomen and pelvis. You'll have different numbers for different body parts, but because abdomen CT is so common, I think it's worth memorizing. For kids, try and keep your DLP less than 200. For adults, try and keep your DLP less than 500. And again, if you come back and decide these numbers are too extreme, maybe they're too conservative, that's great because I've gotten you to think about what are your doses, and with your equipment, what are you able to achieve diagnostically that you've tried to optimize that. And then I feel like I have succeeded with this lecture.